Janine Gracie, Project Director of the Heartland Telehealth Resource Center, serving Kansas, Missouri, and Oklahoma. On behalf of all of the regional telehealth resource centers, welcome to our monthly webinar. We're extremely excited to host this month's webinar that will provide you with excellent information regarding COVID-19 and telebehavioral responses across the lifespan. But before we get started, I'd like to provide some information concerning our telehealth resource centers. There are 12 regional telehealth resource centers, so please take a minute and find your regional TRC. It's also important to note that there are 2 national centers, one that focuses on policy at the Center for Connected Health Policy, and one that focuses on technology at the Telehealth Technology Assessment Resource Center, which we all know as TTAC. The telehealth resource centers are funded through HHS and HRSA from the Office for the Advancement of Telehealth. Telehealth resource centers in some shape or form have been in existence for over a dozen years and were established to provide assistance, education, and information to organizations and individuals interested in providing medical care at a distance. Our mission is to expand that availability of healthcare to underserved populations. And because we're federally funded, the assistance we provide is generally free of charge. And boy, have we been busy the last few weeks. Some tips for today's webinar. Your phone has been muted, so no worries there. If you have content questions for our speakers, please use the Q&A feature at the bottom middle of the screen and just type in your questions, and we will do our very best to answer those questions. And if we do not get to all of your questions, we will certainly follow up with you. And for any unanswered questions, please contact your regional telehealth resource center. And you can do this by going to the link on the slide, telehealthresourcecenter.org/contact. This webinar is being recorded and will post to the National Consortium's YouTube channel at youtube.com/c/NCTRC. Our national experts are Christine Calouro, who is with the National Telehealth Resource Center on Policy, known as the Center for Connected Health Policy, and she will provide a Medicare update, which is no small feat. Next will be Jonathan Neufeld, and he is the PI of the gpTRAC, which is Great Plains Telehealth Resource Center and Assistance Center, covering Iowa, Nebraska, North and South Dakota, Minnesota, and Wisconsin. And he will give us some basics of telebehavioral health. And then we'll hear from Jay Ostrowski, who is the director of the Telebehavioral Health Center of Excellence and CEO of Behavioral Health Innovations and Adaptive Telehealth. He will help us navigate the Center of Excellence resources. Then last but not least, we will hear from Dr. Eve-Lynn Nelson of the University of Kansas Medical Center and PI of the Heartland Telehealth Resource Center. She will help us navigate resources for providers and consumers. You're in for a real treat. So Christine, I'm going to toss it to you to get us started.
Great, thanks Janine. As Janine mentioned, my name is Christine Calouro and I am a policy associate at the Center for Connected Health Policy. We are the National Telehealth Policy Resource Center under the NCTRC. Next slide. We always like to start with a disclaimer, just that I and CCHP are not providing legal advice today, and that we have no financial interest in any of the products that I may mention. And just to get a little bit on the same page for what we mean when we say telehealth, we really define it very simply as using a technology from a distance. And there are 3 primary categories of telehealth. The first is live video, which is a live video contact between a patient and provider, basically just like it sounds. The second is store and forward, which is a recording of information in some way, either photo or video, and then sending it to a healthcare provider who reviews it at a later time. This happens a lot with dermatology. The third telehealth category is remote patient monitoring. These are devices that continually monitor health data from a patient, typically at the home. For example, measuring blood glucose levels for diabetic patients. And then there is a fourth area of telehealth for mHealth, which includes healthcare activities done from a cell phone, tablet, or mobile app. However, this area is still developing and policy rarely addresses it. Next slide. Oh, this is the disclaimer slide. Next slide. So let's jump right into a Medicare update very quickly, because this is only supposed to be a 10-minute presentation. So I will try to be as succinct as possible. So as you may know, prior to COVID-19, Medicare had one of the most restrictive telehealth policies out there. And some of the things that made it restrictive have been relaxed due to COVID, and others have stayed the same. So this chart is a summary of Medicare pre-COVID policy versus now, so that you can kind of see what has changed and what has stayed the same. The first item that I have listed is that modality category that I just went over, the 3 telehealth modalities. So CMS currently will only pay for live video telehealth. Store and Forward is reimbursed in Hawaii and Alaska demonstration pilots, but other than that, they only pay for live video. That has not changed with COVID. Now, the CARES Act did give CMS the ability to expand reimbursement to other modalities, such as the telephone, but they decided not to do that under the telehealth umbrella. Instead, they are allowing telephone as a reimbursable service, but it doesn't fall under this telehealth category. It has its own unique separate codes. And I'll talk a little bit more about that later. But now I'm only talking about live video telehealth. So another restriction Medicare had before COVID-19 is that the patient had to be located in a rural area. And that restriction has been completely removed. So the patient can now be in a rural or urban area. Pre-COVID, Medicare also restricted the location of the patient to specific types of healthcare facilities, such as a doctor's office or a hospital. But now, during COVID, a patient can be located anywhere, including in their home, which is very convenient for this time of COVID. And then Medicare also restricts the eligible providers that can deliver a telehealth service. This has not changed very much. CMS has added FQHCs and RHCs as eligible distance site providers, but other than that, the list has not changed. And you can go to the next slide. So this is the list of eligible telehealth providers, and with the CARES Act, as I mentioned, FQHCs and RHCs can be those distant site providers. However, the legislation said that they would be paid off of their the fee-for-service rate rather than their typical PPS rate. And we are expecting further guidance from CMS on how they are going to implement this, but we have not seen that yet, and so we are expecting that to drop any day. Next slide. Another recent change Medicare did was expand eligible telehealth services that would be reimbursable. So before COVID, they had a list of about 120 different CPT or HCPCS codes that would qualify. They have now expanded that list to include a wider variety of codes. And I have listed some of those services on this slide. Note that although physical, occupational, and speech therapy services were added as an eligible service, those types of providers are not eligible providers. So if you think back to that previous list of eligible providers, they are not on it. So although those services are reimbursable, they cannot be delivered by physical therapists, occupational therapists, or speech language pathologists under telehealth. CCHP also gets a lot of questions about the proper place of service code to use during this time. And prior to COVID-19, you were supposed to use O2, place of service, to signify the service took place over telehealth. However, at the beginning of April, CMS is now saying to use the place of service code that is consistent with where the service would have taken place if it was done in person. So probably the clinic or an office. And then you would use modifier 95 to indicate that it took place over telehealth. This is so that you can get an appropriate non-facility or facility rate, whatever is associated with that place of service code. But they will still accept O2 place of service as well if you choose to keep doing it that way as well. Prior to COVID, if a provider was delivering a majority of their services from their home, they needed to register that home address with Medicare, but that has been waived currently as well. Then finally, there is a facility fee. If the patient does physically go into a medical facility, they can collect that facility fee. And if you go to the next slide, these are the facilities that are eligible for that fee. You would bill the code Q3014, and you would receive somewhere around $26. Next slide. A few other things to note is that the Office of the Inspector General is currently allowing healthcare providers to either reduce or waive out-of-pocket fees and copays. And CMS has also temporarily waived requirements for Medicare and Medicaid for out-of-state practitioners. Keep in mind that this only applies to the Medicare and Medicaid programs, and state licensing laws would still apply. Some states have relaxed their in-state licensing requirements while others have not. The Federation of State Medical Boards has a really good chart on their website where they're tracking this information. And then there has been a relaxation of Stark laws as well. Next slide. Finally, as I mentioned earlier, when talking about telephone, Medicare will reimburse for a number of other technology-based remote communication services that don't fall under the telehealth umbrella. While for telehealth, you can bill for the normal CPT and HCPCS codes that you would otherwise bill in person as long as it's on the telehealth list and get paid the same as you would in person. These services have their own unique codes associated with them and are tied to their own reimbursement amounts. So we have things like the virtual check-in, G2010 and G2012, the interprofessional consultations, remote physiologic monitoring, online digital evaluations, and telephone services that fall in this area. I have also included on the right-hand side whether or not these codes can be billed by FQHCs or RHCs. What is good about these codes is that they provide an avenue for providers who may not qualify as an eligible distance site provider under telehealth to still get reimbursed for their virtually delivered services. But each of these codes have their own unique requirements associated with them. For example, the virtual check-in codes, you can't have seen the patient within the previous 7 days for a related condition or see them in the next 24 hours or soonest available appointment. So each of the codes have like their own nuances that you would want to look into to see if they fit what you're doing. Next slide. This is just a list of reference material for all the Medicare items I covered today, just as a reference. Next slide. Just also wanted to quickly mention that the HHS Office of Civil Rights is currently practicing enforcement discretion if providers want to use everyday technology currently, such as FaceTime and Skype. But note that states may have stricter laws and regulations on privacy and confidentiality, so you should definitely check with your state to find out about those. Next slide. And then the DEA is also currently allowing for the prescription of controlled substances utilizing live video telemedicine as long as certain conditions are met, which is more expansive than they were doing before. And the prescription of buprenorphine specifically for treatment of opioid use disorder can be done over the telephone currently. Next slide. And then this is just a resource page for some NCTRC and CCHP materials and other organizations who have released materials that CCHP has found helpful. Next slide. And that concludes my presentation. I believe we're going to take questions at the end of everyone's presentation. So I think I will toss it to Jonathan now for telebehavioral health basics.
All right, thanks, Christine. And you can go ahead and skip this slide. All right, so to underscore something that Christine just brought up, just to kind of orient us when we're talking about regulatory, the regulatory environment, there are a range of federal regulations, and with regard to what you can or can't do, and that is basically about privacy, the HIPAA and Stark laws, and prescribing controlled substances, the DEA. But the other regulations that happen at the federal level are Medicare regulations, but they're basically reimbursement. Medicare doesn't tell you what you can or can't do, but they do tell you what you can or can't get paid for, and that is often just as important. Okay, next slide. What really tells you what you can or can't do as a provider are the state regulations and licensing boards. Every individual healthcare provider is regulated by their license, the license they hold, and that license is regulated at the state level. Now, as Christine said, there have been some relaxations so that, for example, many states now say if you've got a license in good standing in some state, in some other state, then you can practice in our state by video or virtually for the duration of this emergency. And most of the time, I mean, the primary application of that is it's not so that people will set up, hang up a shingle online and set up, nationwide telebehavioral health counseling programs. It's so that folks who would normally drive across a state line to go to a clinic to get their health care, which happens all the time in border towns, border communities, those providers who are licensed in the state where the clinic is won't run afoul of licensing boards if their patients are back at home across the state border and they have a virtual visit with the clinic. So that's primarily the use case that we're trying to be sensitive to, or that states are trying to be sensitive to in loosening these restrictions for the emergency. Next slide. In general, a couple of general points. Video encounters should always be encrypted, and that's according to HIPAA and high-tech regulations. You should always have consent for them, and they should almost never be recorded. Usually, or you would need to have a separate written consent in order to record a session. And I bring this up because it's the #1 question people ask when you're doing a video call, a live video call, is, are you recording this? Sometimes patients will even assume that it's being recorded. And so you need to be clear about that up front. Using patient equipment like their cell phones, their computers, their Wi-Fi network, it's problematic in a lot of ways. I mean, right now we have to do it, but recognize that that exposes a lot of potential PHI to platforms. And so having BAAs in place are the mechanism through which we normally ensure that that PHI is not exposed unnecessarily. And of course, right now, those HIPAA regulations are being relaxed, but we need to recognize that this is a temporary situation and recognize that that PHI is still out there and will be being collected after the emergency as well. So it may be the best practice to think long-term here, recognize that you have some flexibility now, but think long-term in terms of making sure that that healthcare information is secured. Next slide. So when it comes to billing, and Christine also touched on this a little bit, I'm going to underscore a point that is of critical importance to me anyway. Recognize that reimbursement policies vary by payer, right? We all know this now. If you work with multiple payers, you recognize that policies vary by payer. But recognize also that telehealth billing policies, and I don't just mean live video telehealth, basically any sort of technology-enabled service, those billing policies also vary by payer. I wish it weren't this way. I wish we could pick a standard and go with it, but recognize that there is no one right way to bill for virtual services or technology-enabled services. There isn't even one right name for them, as Jay will probably point out to you when he talks, because he's looked into this extensively. There are right ways. There are many right ways, one for each payer. So just be aware of that, and when you see information flying around about you got to do it this way, you got to do it that way, make sure if it's not qualified by a payer, then it may be incomplete information at best. And these are all changing, so we need to stay in touch with sources of information, reliable sources of information. All right, next slide. Thank you. Telebehavioral health in Medicare under the public health emergency. So I'm going to focus on Medicare a bit here. And just give a little historical note. Medicare has been consistent, very consistent in its telemedicine, telehealth billing policies. They have always been fee-for-service based on specific CPT codes, live video only, office and clinic based, and rural limit. As Christine pointed out, in the public health emergency, Medicare relaxed a lot of restrictions and changed those policies to allow much wider use of various services. Now it's allowed from any location, including patient homes, and a bunch of new codes were added that you can now bill, along with the use of the telephone, both allowed and reimbursed at a slightly higher rate than telephone calls were being. They weren't being reimbursed, but separately, the RVUs for those telephone calls have been bumped up a little bit so that we can get a little more money for those. Next slide. Recognize also, though, that, and again, in Medicare, Medicare has used some specific terminology, and unfortunately they claimed one of the terms that we had been using in a generic sense, the term telehealth now, which can be used in a generic sense to revert to all telecommunications enhanced or virtualized care. Now Medicare is going to define it specifically as live video encounters that are billed with CPT codes and with place of service 02, even though they've modified that just a bit. Right now we're using the usual place of service, and we're going back to 95 for a bit. But Medicare is now claiming that telehealth term to mean live video only. E-visits, is a new terminology that refers to technology-enabled visits, possibly asynchronous, using web-based communication with images and audio. Telephone E&M now is getting thrown around, audio-only interactions. They're billed with specific telephone codes. But just recognize this whole slide is meant to point out the fact that there's a lot of terms being thrown around now, and differentiating them is critical. Make sure you understand that Medicare is going to use these terms in specific ways, and when Medicare uses them in those ways, they have a pretty consistent application. They don't play very fast and loose with their terminology. Other payers, though, are going to use the same terms in multiple ways, and so we just need to be really, really aware of all that. Next slide. This slide is to point out, and it looks like some of my highlighting and colors didn't translate too well, but is to highlight a sort of a spectrum, or at least 3 different types of services, and recognize that the services on the left side, and let's see if you click the mouse one more time, like advance this slide, I think I get a, yeah, there we go. The services on the left, these, although they're billed with slightly different codes, they lump together in terms of reimbursement. These are fairly low reimbursed terms under Medicare, and are entirely distinct, as I made the point before, from the terms on the right, the telehealth term, the live video term. And the telehealth is billed by a CPT code and varies in levels of time and intensity, but in general, these are higher reimbursed codes. And the other codes, the e-visit codes and telephone codes are going to be reimbursed at a lower level. So when organizations are making decisions about Medicare, at least as a payer, thinking about it this way can simplify this decision a little bit. Next slide. Also recognize as a behavioral health provider that most of your bread and butter codes are Medicare telehealth codes. I've highlighted the 907, 91, and 2, the psychiatric diagnostic interview codes at the bottom there of that highlighted area. The psychotherapy codes are up a couple of lines, and then the health and behavior codes up a couple of lines. Just about everything you do in behavioral health is a Medicare billable code by CPT, so you can get that same code paid for by Medicare if you do live video. Next slide. Also, as Christine pointed out, the originating site facility fee is available. Next slide. And to underscore, if you're talking about Medicare, you need to know about Medicare and other payers. We can't give you a 50-state rundown, 50 state times however many commercial payers they are, multiple different ways of billing. So your key concerns, of course, are whether or not and how they cover telephone encounters, because that is kind of the bottom common denominator that we have to deal with now. Whether what the allowed patient and provider locations are, specifically the home. And again, most of the time, almost every payer that I have come across, every commercial payer has allowed those patients to be at home. What billing procedures specifically they want you to use, and what reimbursement rates they're going to provide for those. Recognize that some payers are imitating Medicare, but not all. And so they may have their own specific billing procedures. And your resources on those, your best resources here, are the state and professional associations, and you can reach out to the TRCs as well. Next slide. Finally, a few resources to look at. Under Medicare, there are plenty of good places to get these links, and Jay is going to point out a few that are referred to by the COE, but I provide these as reference. Next slide. There are also some really nice references that I want to call out from our colleagues at the Addiction Technology Transfer Centers, which are funded by SAMHSA. The mental health side of the house, we're funded by HRSA, the medical side. And then a couple of nice collections of resources online. Kathy Wibberley at Matrix Mid-Atlantic Telehealth Resource Center does a great job of pulling together resources in her COVID summary page. And then I want to call out telehealthquickstart.org. This is a page that the Great Plains Telehealth Resource Center has put together of resources for our region as well. And next slide. Finally, just to underscore, when you're learning a new skill like this, get your providers to practice yourself. Nothing beats being comfortable, getting comfortable with the technology platforms you're using. It does translate to your patients. I'm a clinical psychologist. It translates to your patients. If you're nervous about how things are going to go, if you're worried about how things are going to look and how a session is going to run, then that translates over. So get yourself comfortable and make sure that you know what you're doing and feel confident in what you're doing before you get online with patients in a live context. And I will pass the baton to Jay to take over from here.
Great, thanks, Jonathan. I guess I want to echo Jonathan's comments. A lot of this is about practicing and developing new practice habits. So what we've done at the Mid-Atlantic Telehealth Resource Center is to create some resources to compile all this together. At first, we were thinking about making a toolkit, but the problem with making a toolkit is that there are many different ways of practicing telebehavioral health. As Jonathan referenced too, there's many different terms. If you go to your licensure board and try to look up the law, sometimes it can be a bit frustrating. So when you look at the regulations, you need to look for what term does that state licensure board call it. We track 8 different licensure boards in all 50 states, and there's in some states there are different terms used. They may not use telebehavioral health or telemental health. They may use distance counseling or by electronic means or digital health, something to be a very big, broader concept. So to help narrow the field and help people kind of onboard faster to telebehavioral health, we created this Telebehavioral Health Center of Excellence. It's a suite of resources that are vetted by people that do this for a living. We keep it very vendor neutral, so you're not getting a sales pitch, you're getting the really good information here. And we have just a lot of resources, so I'm going to spend just a little bit of time telling you about what those are. First of all, because of COVID, we just made it plain and simple. Click here for COVID information, just to kind of make it really simple, because everybody's a little bit stressed these days. So there's also quite a lot of other information, and just kind of give you a quick view here. You could type in that search box, the blue one in the middle. You can go to different sections here. In the middle of the screen, there's technical assistance requests or speaker events. We have announcements and information about our region, different regions. We also, in the middle, you have hot topics, which is a drop-down list of different topics, and telebehavioral health is one of those. The Center of Excellence for Telebehavioral Health is one as well. When you click on the COVID page, we've put some telebehavioral health resources here. We're trying to make a real clear breadcrumbs to kind of the quick start references. So we have here some little accordion menus. One of them is getting started with telebehavioral health. Telemental is usually the counseling side. Behavioral health is usually the psychiatry side. But SAMHSA will combine them all and call it all telebehavioral health together. No hyphen, by the way. There's a link here in blue to the Center of Excellence, and then another one to some video, kind of a 40-minute quick start video we did just real recently to help people know what are the things to think about and worry about as you get started. And then there's a list of references here in different bodies of information. One of the hardest things that you might already be feeling as you're watching this is that there's just a lot of information. And that's why we started this center, is to help people narrow down. Even as they narrow down, there's a lot of information. So depending on who you are, you're going to need different information. And we try to make that easy for you. But if there's something that you need, you can just simply contact us and we'll help you find that quickly. But we think we've laid it out pretty well. But again, everybody is doing it a little bit differently. One of the things that you'll also find is that some people say, just tell me what to do. And we'd love to be that directive and help you. However, it's really kind of case by case usages. You might be doing, even though we're doing a lot of direct consumer care, a lot of this depends on your population, what they're capable of doing, or the type of services that you're doing. And quite a lot of other factors as well, the technology that you use or want to use. So what we want to do is, because of the emergency, we want to help people get as much care as we can and simply, but also we advise that you think long-term about this. So you might have like your own emergency response and your temporary plan, but what you'll find soon is that this is not going to go away quickly, this emergency. So this will be kind of a new normal, that we'll be doing a lot of this online because the virus is going to kind of have fits and starts for a while. And even when the pandemic is officially over, the fear of getting the virus will remain for a while, and the impact on our economy. So I would highly recommend thinking about this as a line of service that you will continue indefinitely. You're also going to have patients get a taste of this, or providers that get a taste of this and go, hey, why don't we continue to do this in some way? So it doesn't mean that all of your practice needs to do this online, but I would highly recommend having a line of service continue. So again, that's more of a long-term plan. I would recommend starting in some small iterative way immediately if you haven't already. And there's some good guidelines here for that. But think long-term, or how you're going to continue this. And a lot of it is going to have to do with workflows. How do you make efficient, fluid workflows so that every stakeholder involved, your staff and the patient, have just a positive experience, and it's not clunky and disjointed. So that's the kind of the holy grail of this, is to have a very fluid, easy workflow. And it might be something you just incrementally work towards, or basically iterate over time. So as you see on this, you have the little green arrows. They're not actually on the website. They're here to help you navigate my slides a little bit. Again, there's a lot of information. If you look at the very bottom, there's one that goes down, because if you scroll down on that website page, there's another section just for FQHCs. We get a lot of requests for what do FQHCs do? And in the past, it's been a struggle for them to provide telebehavioral health care. And now there are some ways to do that and ways to get reimbursed. So we made a special section just for that. Going back to the homepage of Matrix, MATRC, I wanted to show you how to get to the Telebehavioral Health Center of Excellence. There's a lot of information there. And so if you look down, there's some videos, little like 1-2 minute videos that tell you, here's what telebehavioral health is. If you need to give your staff a quick introduction to here's how to get their head around this. Another one is about HIPAA compliance and how that applies here. And then a third one about clinic to clinic work versus direct to consumer work, because there are differences in that. If you scroll down on that page, there are even more sections: clinical guidelines, crossing state lines. As Jonathan mentioned, some of the states are loosening that just temporarily to allow people to not get dinged for their license if you have a valid license in one place. But again, it's not a national strategy. If you are thinking about expanding this and you're kind of an entrepreneur, you're thinking about this, realize that the laws and the regulations are different, or can be very different in every state. Not just the requirements, but for being licensed, but also what they require at the time of visit. So that just keep that in mind, that could be different. So you don't want to think, oh, this will be easy. I have a license, I'll go in every state, because the regulations will apply. Generally speaking, each state considers where their patient or the resident is located as the jurisdiction. So that means if I'm in Kansas and I'm receiving counseling from somebody in New York, it's a Kansas regulation that's going to apply. However, New York might also have a regulation for where the provider is located. So these aren't intended to be prohibitive, but every state thinks of their own domain. So you have to think of it from their point of view. And there are we do have resources here on the site that can help you navigate that. Again, these are just, again, bigger boxes to kind of illustrate, links to training, links to MAT, technology selection, HIPAA security, things like that. On the note of HIPAA, I just reiterate that they've loosened the enforcement of the regulation, but they're still highly recommending that we use HIPAA secure technology. We say HIPAA secure because no technology by itself can be HIPAA compliant, because the technology itself is not a covered entity for whom the laws apply. However, some technologies do a better job at HIPAA compliance than others. So just keep that in mind, that you're looking for a technology that has probably a long list of things they're doing to protect that. Because especially in behavioral health, we don't want to have PHI, if we can help it. We don't want to let PHI is protected health information. We don't want to let that information out if we can help it, because we don't want people to be found out as receiving mental or behavioral health care. So there are quite a few technologies out there on the market, and there are ways to select those. If you want additional help from me or Center of Excellence, we do have open office hours every other Friday, 2 hours on Eastern Standard Time from 12 to 2. So you just go to our Matrix site, scroll down Matrix page, and click here to join meeting. So that's it for me. I'll pass on to Eve-Lynn. Thanks.
Thanks, Jay. That was fantastic. I just wanted to chime in. Several of my colleagues have been using your video resources and found them super helpful.
Cool.
With my presentation today, I take the teleprovider perspective. So like many of you, I'm in the tele-trenches. I've done telehealth a long time, but it's a new ball game in the home. As I was getting ready to start, there's a lawnmower outside, so it made me think, gosh, how am I thinking about that with my patients too? I'm going to share my perspective as a psychologist. I think many of the things that are talked about will have crossover to psychiatry, nursing, behavioral analysts, and many others doing telebehavioral health. But just in the interest of full disclosure, I know that some of mine is kind of biased to my experience as a psychologist. Oh, before I move on, I also just wanted to share my appreciation for this information is supported through several of the Office for Advancement of Telehealth funding. None of us have a COVID crystal ball. I think the message from my provider perspective is similar to what we've heard from all the speakers. Whenever possible, if we're following telehealth best practices from our professional organizations, and we're aiming to follow all ethical best practices, just as Jay just mentioned, when we can, using the best HIPAA secure technologies, that will really help us now and as we look long-term into the future. With the technology, I think right now many of us are experiencing, wow, we could do telehealth anywhere, any place, anytime. So it does just remind me of keeping cultural competence and cultural humility in mind, really thinking, do I as a provider have the cultural competence as well as the technology competence with the population that I'm looking to serve? And if I don't, how can I bridge that gap with some additional mentoring or those sorts of things? I think there's the now, and then as we kind of have our feet on the ground, also just really trying to keep in mind the family's community values and resources, and using as much as possible our culturally sensitive protocols, following all good medical interpreting best practices as well. I think, we're all kind of trying to meet the balance of high need and equity. So also as we're looking at our telebehavioral health practices, how can I make sure that with our underserved families, both urban and rural, how can we still provide the best telebehavioral health services, thinking through what access is there to technologies as well as the family's access to connectivity. Again, this is coming from our program's perspective. With this slide, it's just to describe we're translating a school-based telehealth program now to home-based services. So just thinking across the range of the different types of, in this case, pediatric behavioral that we provide, it's really looking at what our best evidence-based interventions are, and then translating them over telehealth, like I said before, to the schools and now to the home. And just to say, across these strategies, we've had good success with taking that approach and thinking thoughtfully about how to then share those same interventions to the home. The one that, so you'll see there's family and behavioral therapy, medication management and consultation, different parenting and prevention strategies, assessment, feeding and weight issues, and then also the toileting clinic. The one that's probably had the greatest change has been our autism assessment clinic. It's a really innovative clinic where it more utilized school teams on the ground, and that team was supporting the child and family and connecting them up with the autism assessment team. So there's been some challenges to the home because that whole school team, how do we continue to have their involvement? So I know that team has in process some creative ideas on how to bridge that with including the school team within the appointments to the home. Right now they're looking at more a middle step where it's some diagnostic interviews in the interim to give some ideas about strategies while there's a wait to the full autism assessment. On the other side of the age range, we also have the Kansas Telebehavioral Health Network. And this is a project that serves our rural affordable care organizations. And there's many elders seen through this behavioral health project. Many of them have multiple chronic conditions and a lot of need around the behavioral health part. What stands out with that project is with our elders, they have accommodated well to the home. I think it was a question mark, how will people accommodate? And by and large, it has gone well. One thing that's really helped with that is, of course, leveraging existing relationships with the telebehavioral health coordinators and continuing to use their help in preparing the patients for the telesession. And there have just been early benefits of within that project. We're showing greater show rates, and then also because of COVID, we have a little more psychiatry availability. So as we think of just some very practical things and planning to deliver telebehavioral health to the home, we really encourage taking a proactive continuous improvement philosophy as we're initiating and continuing telepractice. It really rang true what all the speakers were sharing about training and having that training throughout the course of practice. We're all learning new things every day, so thinking about ways to connect with peers and colleagues who are also providing telehealth and sharing those quality improvement lessons about what's working and what's not. Just some general things to keep in mind: assessing the patient's appropriateness for in-home telehealth, weighing risk and benefits, often around potential for any crisis, considering risk associated with an unsafe home, for example, an abuser in the home environment, as well as any risk of medical emergencies. With children, of course, we're thinking through some about what are risks in the in-home telehealth, about elopement, aggression, any self-harm concerns, and then any unsafe behaviors toward the child. We always, of course, discuss and document emergency procedures as part of the informed consent process. And really checking each time with the patient, what's your local emergency resource, and what's the good contact that I can get back in touch if we have a challenge with the technology. We do often consider a release of information to contact a family or community member if there's a concern that additional supports may be needed. And then just with more cases where there is a concern about safety, thinking through ahead of time, what's the risk associated with that in the in-home setting. With children, we do consider more family support plans, really laying out on paper, if there is that risk, what's our plan together with the family to mitigate that risk. And then also discussing with the patients up front any potential costs, including costs associated with their data plan use. So that was from our provider side. From our patient side, I just summarized some of the patient tip sheets that we're using. A great first step is the telehealth resource centers, how patients can engage in telehealth, as well as many excellent COVID-19 patient tip sheets. I just put a couple that we've used from the National Child Traumatic Network, as well as the National Center for PTSD. Our system has been very thoughtful about how do we provide simple technology instructions across patient language needs, and just encouraging basics about checking in connectivity, power cords, and startup before the appointment. We're encouraging folks to think about a safe room with a door when possible. That's not always possible. So thinking about, well, what's good enough that can meet the patient's needs and still help provide the best possible service. Thinking through dues and having this at the family's fingertips, joining from a quiet place, not walking around the house with the tablet, and talking about how that really helps you as a provider pay better attention and really help make the best of the time you have with the patient. The other one that we've seen a lot with more research protocols is folks trying to join while driving, folks joining from outside or less secure areas, and generally it's just gentle reminders that we then try to remind the family that, hey, in following these tips, it really helps us, again, meet your and your child's needs. Setting the stage at home. We've talked about a number of these throughout our presentations. We do make sure we're reminding families of confidentiality and its limits, including requirements around mandated reporting. We are reminding our providers to follow all documentation best practices. We've talked about connecting and making sure we have the family's callback number. Just as the families, just reminding ourselves to minimize distractions in our workspace, and considering the lighting and space needs, depending if you're seeing one adult or you're seeing a family with multiple children, really thinking through is, what's going to be the best location within what's available. Checking the video screen, and kind of, again, just best practices that you'll find with your professional guidelines about maintaining your gaze into the camera. And then, things like using picture-in-picture kind of for the provider to be able to check themselves. We, of course, do introduce the technology. I think what we're hearing from our folks that new to technology is just thinking through the process component as well as the content that they're providing and using the same good rapport skills. Checking with the patient see if they have used telehealth before, and being transparent about what the goal of the session is. Is it to provide the same therapy as you would in person, or is it a brief check-in? Just, making that clear. And then, you know, as much as possible, preparing for technical difficulties and having the technical support available. And then providing multiple times for the family to have the opportunity to ask questions and checking in with them throughout about what's the experience like of being seen over the technology. Keeping patients engaged. Again, there's a ton of great things coming out across different types and of behavioral settings. Sharing handouts has been an option. You know, with kids, having them show something they just drew, or engaging using some of the screen share options. Considering slightly exaggerated expressions or gestures to engage, especially young children, your virtual high fives, asking kids about, you know, some of their favorite things in their household. And then with kids, of course, we're also trying to think, how do you behaviorally reinforce keeping them on the screen so you can see and work together. And then just in summary, again, we're learning every day, but I think what we're hearing so far is that the consistent with telebehavioral health findings in general, by and large, there's more similarities than differences in telehealth care. There has been the pandemic's impact on individual patient symptoms and on their resources to gauge in treatment. That's been variable across families. There's not one diagnosis that's been now excluded from telehealth, and just thinking about and continuing to monitor that individual patient's response. There's been, of course, a real uptick in interest in general parenting resources across our adult and child patients as parents are balancing multiple work, profession, responsibilities. What we've seen overall, there are some barriers and challenges, and I'm sure many on this call could contribute to what they've seen on the barriers and the facilitator side. With barriers, some common things are thinking about safety, thinking about access and familiarity with the technology, and then providers also juggling many work-home responsibilities. And then with facilitators, patients are often taking pride and excitement in sharing things in their home. It does give the clinician a better picture to help tailor the intervention. For example, in one of our healthy lifestyle interventions, children with obesity can actually show you into their cabinet and, you know, kind of talk through together and look at food labels together, and those kinds of things have been beneficial. And then for some patients, use of the home environment has been really meaningful in talking through some of their grief issues and other concerns. Sometimes that environment has really been a bonus. And then I know that we just barely have time to touch upon some of the resilience and using telehealth to help with resilience with our healthcare workforce. I'll just briefly say we're on site. We're doing a lot of things with the 10 facets of resilience and providing supports to teams. We're adapting that using telehealth then to provide some of those same resources with our rural ACO sites. And then really ramping up some of the general behavioral health resources for our primary care teams. And then planning now for some of what we see coming in terms of healthcare teams and families related to loss and grief. I'll just summarize. I think one thing that I think about with telehealth and these 10 facets is how it really aligns with hope in some ways. With hope, we always talk about what's your end goal and what's your pathways. So our end goal is to provide the same good care and continuity of care for our patients, and telehealth is one of those pathways to help continue to do that. So thanks for your attention. I appreciate the opportunity to talk together.
Thank you so much to our speakers. That was a wonderful presentation, and there were several questions in the queue that have been answered and they continue to be answered as we go along. We're not going to be able to do a question and answer live today with so many participants. Thank you so much for joining us. We want to let you know that our next webinar will be next month, May 21st, and we're going to be talking about inpatient e-consults. So mark that on your calendar and make sure you register for that particular webinar. And definitely, your opinion matters to us. Please participate in a brief survey just to let us know what you thought of today's webinar and how we can continue to meet your educational needs through this series. So thank you for spending your valuable time with us today, and we hope to see you next month. Have a great rest of your day. Thank you.